So for metastatic disease, like I said before, the goal is to keep the patient in good health and try not to inconvenience them very much with the side effects of the treatment. So when she had cancer recur in her lungs in 2017, and she had minimal side effects, she was just coming in and she was feeling good, I would have chosen an endocrine agent. And the options for treatment at that point would have been an endocrine agent alone or an endocrine agent with a drug that makes the endocrine agent work better, like a CDK4/6 inhibitor or everolimus. And standard of care with people on endocrine therapy at the time for her at this point in time would have been to put her on fulvestrant, which she was started on with one of the CDK4/6 inhibitors, because the response rate's higher and they have longer time to progression of disease. So that's one difference in what I would do now with a patient who had hormone receptor positive breast cancer that recurred. If her disease had been symptomatic, like if she had come in with a lot more lung disease or some other cancer site that was causing symptoms, I would have considered giving her chemotherapy instead of endocrine therapy, because the response to chemotherapy is faster and that she would get faster relief of symptoms, but then think about going back to endocrine therapy later because it was a hormone receptor positive cancer. And it's not very common that women come in with metastatic disease to start with, but when we meet women with metastatic disease who are not on endocrine agents, say they stopped endocrine agents many years ago in the adjuvant setting, or they're just new diagnosed with metastatic disease, it is a lot more perplexing in practice to decide what to do. And the reason for that is because the CDK4/6 inhibitors are more toxic than just an endocrine agent alone, and they're a lot more expensive. So to add a CDK4/6 or other agent that potentiates endocrine therapy adds toxicity and cost to treatment, and not just a little, a lot. So when we're trying to decide what to do first line in a patient who isn't on an adjuvant aromatase inhibitor, we're thinking about an aromatase inhibitor plus or minus whether we're adding this other drug. And we always talk to the patient about the fact that the data that we have available right now says that the CDK4/6 inhibitor improves or lengthens time to progression versus just the endocrine agent alone. But I've been in practice a long time, and I've seen patients who have been on endocrine agents by themselves and one of the aromatase inhibitors, and actually have many, many years of life that's good quality because the endocrine agent controls the cancer, and they don't have to have the expense of the CDK4/6 inhibitor and the cost of side effects of adding that. They just stay on the endocrine agent for 10 years. Problem right now is that the studies compared endocrine agents to endocrine agents plus the CDK4/6 inhibitor and showed better response, but they don't have a marker. There was no study done to say who needs to get that CDK4/6 inhibitor. So right now we don't know who needs to get it and is going to have the better survival with it and without. But I do know that some women don't need to get a CDK4/6 inhibitor, and some will do well on it for decades on just the aromatase inhibitor in the setting of new metastatic disease that's hormone receptor positive and HER2 negative, or someone who had cancer 20 years ago and had endocrine therapy, 15 years ago they stopped it, and now they have a recurrence. So the pace of disease makes a difference, because if it was 20 years ago that they were diagnosed and now they're just recurrence, that's not a fast-growing disease. And symptoms make a difference in choice of treatment. And then we have to think about cost of all these things too.